Well, welcome. My name is Lynn Nichols. I direct the Health Policy Program at the New America Foundation, and I'm thrilled to have you all with us today because this is a very important conversation about California's health reform effort and the lessons that that effort holds for our nation. There's a lot we could say, and I'm going to get out of the way as soon as possible, but I think it's important to try to think about California's experience as an inspiration because of the fact they tried to take on such a gargantuan task with so many uninsured in a state that might be just a little bit complicated compared to the rest of the country. But it's also, of course, a cautionary tale because it didn't quite work out. However, I think it's fair to say that's a lot of what you're going to learn today. There are a lot of things we can learn from the California debate that are going to be applicable both in California in the future and, I think, in the nation as a whole. There are many voices that need to be heard. We couldn't get them all here today. We couldn't make space for all of them, but I will tell you we have among the best articulate spokespeople for various perspectives. And I think I consider this the first of many conversations we're likely to have about what's going on in California as well as the nation as a whole. I want to thank the speakers in particular, and we'll introduce them all specifically in a moment, for coming from California, because it's a long way and flights are not always fun. But I have to take a particular moment to thank Crystal Haley, who will be introduced properly later. Crystal, not only from Blue Shield Foundation of California, is our program's main funder, the main reason we're able to do what we do in California and Washington. Crystal came here on a red eye. So please listen carefully to Crystal and hand her a pillow when she's finished because she is indeed exhausted. She gets the hardest trip award. It's an exciting time for New America's Health Policy Program because I want to take just a moment and tell you a little bit about a new initiative which is, I think, in your hands as you speak in the handout there, because we've started a new project, and we call this project New Health Dialogue. And the purpose of New Health Dialogue is really to do what we have been doing now for some time with Crystal and others' help, but it's really about advancing and protecting a bipartisan, evidence-based conversation about comprehensive healthcare reform. Now I want to take just a moment and introduce three new members of my team that are amazing, and they're helping me make this effort possible. The first is Julie Barnes, standing over to my right. Julie's an attorney who comes to us from the healthcare practice group at Crowell & Mooring's DC office. Julie actually understands HIPAA privacy, she understands ERISA, and she understands how to run an amazing complex set of activities in our office. Dr. Guy Clifton, who couldn't be here today, but I want to tell you about him. Guy's a neurosurgeon from Houston, Texas. You may know him from his recent work in Senator Orrin Hatch's office as a Robert Wood Johnson Fellow. And Guy, being a neurosurgeon and a passionate believer in health system reform, just like Julie, is going to focus on how to make the healthcare system more efficient, and in particular, payment reform and quality enhancement. And the third new member of our team, which I'm quite proud to announce, is Joanne Keenan. Joanne's a freelance writer, covered the health issues for some time, just finished a health policy fellowship with the Kaiser Family Foundation. Joanne writes really well and really fast, and she's our official blogess, I guess I should say. She is our blogger. We started our blog this week, and the blog is a pin attached to your handout, which has the URL, but it's newhealthdialogue.org. We highly recommend you check this out. Now I'm going to get out of the way now and turn it over to Lee Posse, who is the director of the California program for New America. You know, New America has an office here and in Sacramento. And we're extremely lucky to have Leif in Sacramento because not only does he do a great job of handling all the dimensions of New America West, as we like to say, but he actually is a healthcare expert and did a tremendous amount in articulating both our policy and our communication messages in California. So let me turn to Leif.
Thanks so much, Len, and thanks to everyone who's come out here today to discuss the lessons of the recent attempt to reach comprehensive healthcare reform in California. As the paper that New America released today documents, it was an uphill struggle. partly for reasons unique to California, and we're going to hear just how unique from our panelists, and partly for reasons common to reform efforts anywhere. We're going to focus here on what the fate of Governor Schwarzenegger's proposal, the eventual compromise bill, and the year-long process means for the still developing national debate. What happened? What went right? What went wrong, and why? And what does it all mean? In particular, can the unprecedented coalition of policy types, advocates, business, insurers, and stakeholders that supported this bill be sustained or expanded either statewide or nationally? And to answer these questions, we're proud to have with us here today an all-star panel of policymakers from California, all of whom were in the thick of the fray in Sacramento, including the marathon 12-hour Senate committee hearing at the end, lived through the roller coaster ride of healthcare reform, its many near-death experiences, and the final denouement. I'll introduce them very briefly. On the right, Peter Harbage. Peter, until recently, was with the New America Foundation, made major conceptual and practical contributions to the California reform debate, particularly on implementing the individual mandate and the reality of the hidden tax on business as a result of their paying for the uninsured. He's now at the Center for American Progress here in Washington as president of Harbage Consulting. Richard Figueroa is a senior advisor in the Office of Governor Schwarzenegger and one of the main architects of the governor's plan. He previously was the legislative director for California Health Insurance Commissioner John Garamendi, a deputy secretary for former Governor Gray Davis, and has been a longtime health consultant and analyst for the California State Legislature. Betsy Inholtz is the Special Projects Director of Consumers Union, the nonprofit publisher of Consumer Reports magazine. She has areas of expertise in managed care reform, quality and safety, conversions, and health insurance. She began her focus on health policy for Consumers Union in 1997 and served in the advisory committee to the California Department of Managed Care from 2001 to 2006. And last but not least, Dan Weintraub has been the public affairs columnist on the editorial page of the Sacramento Bee. Since November 2000, he's been writing about California politics and policy for 25 years. He's also written a superb book on Governor Schwarzenegger's years in office, Party of One, up here on the table, and hint, hint, it's available on Amazon, hot off the press. Each panelist is going to speak for about 8 or 10 minutes, and then we'll hear from you. Peter?
Great. Am I going to come on? Sorry?
Don't be bashful, Peter.
Just take over and knock stuff down. Try that in California. Thank you, Leif, and thank you, Lynn, for having me here today, notwithstanding my recent change in employer. I appreciate that. And definitely appreciate my time at the New America Foundation. Being at New America in California last year was an amazing experience for someone who is interested in healthcare reform. It was really, I think, the debate there, I think, is really at the forefront of what's going to be a great national debate that is building up, that's going to continue to build up through this year, and that we're going to see in 2009. And so this conversation about what happened in California in that context is really just that much more important. Immediately after the Senate vote, where the bill, the health reform bill, did not pass, the governor held a press conference. He said we have to get at the real reasons for why the bill didn't pass. We can't focus on what people are saying publicly. We have to really think about what the issues are and get at those. And so to be here today with such an amazing panel to talk about some of that is I think going to be very exciting. I'm going to start off by doing a little bit of background, a little bit of context, and really sort of lay the groundwork for the next speakers. And I don't want to take a lot of time to do that, and maybe talk about some of the lessons learned. But of course, it was January 2007 when the governor made his announcement. Both Democratic leaders in the legislature actually announced health reform plans before his. And in part, they said because they were trying to push him in the right direction. They wanted to make sure reform was going to get off on the right foot. And it turned out when the governor's plan came out, it was much bigger and much bolder than I think anyone fully expected, except maybe for his team, except maybe for Faith, in terms of what it envisioned, and he called for universal coverage. Now remember, even just in 2004, in the Democratic presidential debate, you didn't have Democratic presidents calling for universal coverage, the candidates then. So for a Republican governor to do this was an amazing opportunity. And it was really made all the more interesting by the fact that California is really one of the least likely places you might expect to try for universal coverage. You have a situation where you have one of the highest rates of uninsurance in the country. You have demographic issues that make it difficult to, that raise political issues about expanding government programs in terms of immigration issues. You have a budget situation, which this year we're up to a $16 billion deficit in California. Deficits are very common in California, but this one is even a little high for us. And you have a lot of reasons why to think that California could get this done. It's not obvious, and yet the governor had truly set the agenda and had brought stakeholders together, and we had a major conversation. Now, the plan he released evolved over the course of the year. There are many different plans by many different people, and he continued that dialogue until finally in December there was AB1X1 or ABX11, whatever you want to call it. But we're going to simply refer to it as the compromise bill, where you had the Democratic leadership, the governor announced that they had agreed to a plan. The plan was interesting, and even when the governor released this plan, it was interesting in that you can see the major national themes in terms of health reform, in terms of other plans that are out there. You can see the themes in Wyden Bennett. You can see them in the plans announced by Senators Edwards, Clinton, and Obama. We have a very, there's definitely a growing interest in the theme of shared responsibility. And in some ways it even goes back to the 2005 paper from the Center for American Progress, where they outline their vision of reform. Now, I, as well as anyone, can talk about the detailed differences in all of those plans and all those approaches. But I think what's really interesting, and what I want to spend a second on, is really how they were similar. So you have insurance market reforms that people are discussing. One of the key issues in California that we were able to build an agreement around was the notion of guarantee issue, the idea that everyone should be able to purchase insurance. We talked about setting medical loss ratios so that you have overhead and profits and health plans that are capped, setting up a pooling mechanism. An extensive discussion about sliding scale subsidies, an extensive discussion about expanding public programs, expanding both Medi-Cal, which is California's Medicaid program, and Healthy Families, which is California's SCHIP program, again, from a Republican governor. An extensive conversation about quality and cost containment. And then really the two big pieces, both the employer mandate. When the governor released his plan, he called for non-offering, firms that do not offer health insurance to have to pay a fee of 4% fee. The Democrats had a higher percentage in mind, and so there was a lot of negotiation there. And finally, an individual mandate, which of course we have heard a lot about at this point on the national level. And for all the debate in the national level about the individual mandate, we certainly went through that in California, and ultimately got to a place where to see where you can build coalitions around that kind of approach, around the mandate, around employer mandate, and all these different pieces coming together. And so it's so then it kind of begs the question: well, if the plans are similar, between California and some of the national discussion, and even some of the rhetoric is similar. You hear at the national level a discussion of the hidden tax, which is, of course, the cost shifting that occurs between the insured and the uninsured. When uninsured can't pay the bills, the idea is that those costs get passed on to those who can pay, the insurance companies and the people who are insured. You had a discussion around skyrocketing costs and all these other issues, and you see this at the national level. So if the plans are the same and the rhetoric is the same, does that mean the national discussion is headed in the same direction? And I think the answer, and I think, and it'll be interesting to hear from the other panelists, but the answer I think is no. What happened in California was really more focused on politics in the state. I mean, certainly we had a vigorous policy debate. Certainly there were issues around the budget and identifying the financing. But I think what you really saw were that you can build a coalition that can push this forward. At every step of the way, we had employers who would come into the discussion. You know, one of the people would say one of the lessons of the 93-94 debate is that employers are going to be opposed. There was a group of employers who were in support. We didn't invite any of them today. Instead, we asked some of the small business perspective to join us, but there were small businesses who were in support. You had some of the insurers who had come in support. After a vigorous debate, unions like SEIU and consumer advocates had come in. And so in terms of the lessons here, I think there are really three to focus on. One is, again, the coalition building. Not only is it possible, but it has to be done, and it has to start from the beginning. I think for those who want health reform to happen in 2009 here in DC, the time to begin that conversation is now, and to continue it forward. I think another lesson from California is that you need strong leadership, and we really saw that again from the governor and the Democratic Assembly Speaker, Núñez, had provided fantastic leadership in continuing the debate and keeping the issues going and moving the dialogue forward. Health reform is difficult. It's hard. It's a full contact sport. And so you have to really want it. You need leaders who really want it, both within government and then outside of government. There were numerous stakeholders who stepped up to help, again, push the debate forward. And then in terms of the issues, I think that the two primary ones that people really truly need to consider and look at are affordability and sustainability, sort of the two sides of the same coin. It's the affordability to the individual. How much can individuals be expected to pay in the system? How much can they be asked to put in towards shared responsibility and towards a healthcare system that they, under an individual mandate, that they will surely use at some point? And depending on your answer to that question, it directly affects how much money the government has to put in. If you want to make it more inexpensive for individuals, it means you're going to have greater government spending, certainly at least at the beginning, while you're waiting for cost containment and other things cost containment efforts to take hold. So how do you balance that? And that was really, I think, where California spent the bulk of its time. There was a lot of skepticism of the individual mandate at first, and I think that was overcome. And the question really became, okay, so there seemed to be growing agreement. Not everybody agreed. There are certainly dissenters, and we're going to hear about some of that. But there's growing agreement. Okay, if you want everyone to have insurance, then everyone has to have insurance. You have to have a mandate. But then the critical question is, how much did they put in? How much does the state put in? And who ultimately bears the risk? Where is that risk being shifted from, and where is that risk being shifted to? And I think that is at the heart of the question, the heart of the issues. And we're going to hear lots of issues, and we're going to hear some wonderful dialogue about that from Faye, and I think Dan is going to have some great insight into the politics of it. And so with that as a framework, I will turn it over to Richard Gibbons.
Thank you, Peter, and thank you to New America for putting these panels together. I'm going to talk a little bit about kind of the governor's motivations behind this and some of the major takeaways we had in terms of the reasons that we thought we kind of ran through the difficulties that we did, and then kind of talk a little bit about the future. The others will be talking maybe about some of the more intricacies of the politics or kind of how they saw things from their own perspective. The governor's motivations behind comprehensive health care reform for all Californians were clear and are still clear. The status quo is not acceptable for the insured and the uninsured alike. The healthcare system is broken, and that's another thing that people talk about. The healthcare system is broken, and that's what the governor spent a lot of time talking to folks around the state. In terms of large increases in premiums that aren't sustainable, both in the longer and shorter term, ever larger amounts of the insured and underinsured, the hidden tax that we all pay for on behalf of the uninsured, overcrowded ERs, lack of attention to primary and preventive care, lack of focus on chronic care management, and the increasing unease that many people feel about being one step away from bankruptcy in case they have a major medical emergency. California's legislation is a product of very difficult trade-offs and compromises. The product was groundbreaking, and we believe a template for what can be a national healthcare model about how to fix the problem. And just to kind of review the bidding a little bit, and Peter kind of touched this a little bit, but it did provide coverage or expanded access to almost all of California's 5.1 million uninsured, including coverage for all lower income kids regardless of immigration status. And again, Peter kind of touched on immigration as one of those really kind of third rail issues sometimes in politics. Endorsement of the principle of personal responsibility for coverage, otherwise known as the individual mandate. Endorsement of the principle of shared responsibility, which is another kind of term bandied about nationally, which for us included a minimum employer contribution, affordability mechanisms that reached almost 2/3 of the uninsured in California, sweeping insurance market reforms, and you heard about guarantee issue and medical loss ratio, transparency and public reporting, safety net provider protections, comprehensive health and wellness, including a focus on obesity and chronic care management, and Medicaid provider rate increases, primarily to reduce the hidden tax, to kind of help offset some of the cost shift that goes on. So given the social policy advances that we're in, I call it AB1X, everybody has a different name for it, the compromise bill. The Senate action was, I think, particularly disappointing for obviously the uninsured and the underinsured, but also for folks who just really thought this was, would be really a time for government to really tackle an important and difficult issue and see if we could work collaboratively on it to get it done. We weren't able to get it done yet. So what happens? For every 10 persons you ask, you're going to get 10 different answers. And that's probably true. Everybody has their own idea about how this happens. A variety of factors related to both context, substance, and politics have been put forward. I'd like to highlight for at least my presentation 4 issues that were explicitly identified as part of a 12-hour marathon debate that went on there at the end. They're relevant to AB1X, and the first 3 in particular are relevant to really any kind of national, both any state and national debate on this issue. First, there are divisions between some members of the Senate committee. You had some who were very clear in their belief that we ought to be just kind of going through market-based strategies to deal with this, and you had others that were much more comfortable with a much larger role for government. But our bill was fundamentally based on a belief that you had to look for something in the middle that wasn't in the extreme, and envisioned both a role for the private market but with stronger oversight and regulatory reforms. It also envisioned an expanded role for government, primarily through providing subsidies for lower income individuals. It reflected our effort to find a reasonable and responsible alternative to any single preferred approach. And one of the things we really tried to do, and the government really tried to do, is get people to kind of move beyond their comfort level, to get beyond the situation where the status quo was everyone's fallback. And that was a really, really tough thing throughout the process of trying to break the paradigm, so to speak, where everybody's best alternative was always the status quo. And again, we know there's no societal consensus, and again, we're trying to do a reasonable, responsible alternative to the status quo, which is also increasingly unacceptable. Second, we face great concern about the state's budget shortfall. We can't cut money after all. Our shortfall is about between $14.5 and $16 billion. We were faced with the optics of having a health care package that also equaled $14.5 billion, even though it wasn't the state general fund, even though it was funded primarily by outside revenue streams outside the general fund. The optics of doing something this large at the same time we were facing a very large state general fund shortfall was difficult. And we're not saying that the state general fund impact shouldn't be considered, and it's true that our current fiscal challenges have required us to make some very difficult program choices, including cutting health care at the same time we're trying to do expanded access. But I think the governor believes we can't allow the current fiscal circumstances to prevent us from pursuing health care reform in the future. In fact, he thought our fiscal situation highlighted the fact, well, we needed healthcare reform. We need to look for outside funding sources, for example, to try to figure out how to cover ever-increasing Medicaid hospital costs and hospital rate increases, physician rate increases, et cetera. And our healthcare reform was formulated in a way that was budget neutral, and it had some very specific triggers in case either the dollars didn't materialize to fund it, or in case we overspent to actually stop the program at that point. The third concern, and one that will come up in every state at the federal level, was that it was underfunded. And you've heard some streams of this when people talk about Massachusetts and what's going on over there. Our nonpartisan fiscal office, which is kind of akin to your CBO arrangement here, looked at the numbers and indicated the reform effort did carry some risk. At the heart of the risk were questions regarding the adequacy of the monthly premium that we were going to be paying through our purchasing pool, which is going to be covering lots of the newly insured individuals. We thought, and still do believe, that the price, that monthly price for that product would come in around $250. Our nonpartisan fiscal analysts thought it might be more like $300 or so. And some members of the legislature decided this is a great concern, despite the fact that we currently pay our Medicaid contractors 30% less than that, and despite the fact that some of our potential health plan partners came up to the table and said, yeah, we can do it for that amount. I guess, we think there's enough in that independent fiscal analysis for those who want to claim success and move forward to do so, or for those who are concerned to cite the risk. But for us, you can't do something this big without risk. There's going to be some risk no matter what you do. The question whether the federal money is going to be there, or what our employer is going to do, et cetera, et cetera. Whether we had a cigarette tobacco tax is one of the funding sources, and what's going to happen to that in the future. Our big joke is smoke for health. It's just a joke. The fourth issue was one of timing. Our budget had been significantly delayed because of some very protracted battles over fiscal spending priorities. And that seriously delayed debate in the legislature last year in both houses because of that. The California legislative fiscal requirements that required 2/3 vote to raise most revenues also meant there wasn't room to get 2/3 vote. And so that required us to instead go to the ballot to raise the money. And because the timeline to get something on the ballot, raise the money, collect the signatures, that kind of thing, we had to file the ballot initiative even before the eventual Senate vote. And this caused a real time crunch for both the Assembly and Senate deliberations. It made it a little more difficult, for example, to make changes in the bill without having to go back and pull back the initiative, et cetera. So there's time was not our friend in this. It would have been much easier for us had the bill been voted on in December to January, given that we had to go to the ballot, et cetera. The four things that I mentioned are not meant to imply we didn't have opposition from interest groups. Those that were opposed were pretty clear and vocal in their opposition from the get-go. One of the things that we faced was because the proposal was evolving over time, some of the support was evolving over time as well. And so by the time we kind of actually got an agreement, the opponents had a pretty good head of steam ahead of us, and so we had a lot of ground to kind of make up. We made up some of the ground, but obviously didn't make up enough of the ground in that short period of time that we had available to us. So again, we were disappointed with what the Senate Health Committee did. I think the governor knows with pride how far we came in just 1 year, and it was just 1 year. Other states have done this, and they had a pretty good run-up before they actually did something, but for us it was really just that 1 year period. We were happy that in terms of policymaker attention to problems of coverage and cost and the tension between the two. And that was one of the first time we actually had the debate in the legislature about the politics and the tension between coverage and cost. The public awareness of the program, the general public support for the framework, it was pretty much stayed in the 60s or 70s the entire time. People kind of got what we were trying to do and were supportive. The strength of the framework for reform and all the different kind of components I talked about, and the broad coalition for comprehensive reform. I mean, we could have filled up a cemetery with the kind of articles that were published all during last year talking about how healthcare reform was dead, but we kept moving inexorably forward, kept trying to make the coalition bigger, kept trying to make the changes we needed to make to get that broad agreement. I think we believe we have a great framework for moving forward. There was much agreement and common ground established among a wide diversity of stakeholders, including commonly shared and essential goals, important principles such as the endorsement of personal responsibility for coverage. When we think about it, it was just amazing over the last year. And Peter touched on this a little bit. the idea of an individual mandate prior to the governor putting it into play in California again was primarily considered, well, that's a Massachusetts thing, it was a Republican governor. By the end of last year, it became a Democratic principle because of the changes that had occurred in some of the Democratic presidential candidates' platforms and the frameworks that they were talking about. So what was almost a Republican thing was now a Democratic thing. And that really made the Democrats in the legislature go, wow, especially because they were supporting some of the major candidates that now had individual mandate as a central focus or locus of their health care plan. We had an agreement on important principles also, such as share responsibility for financing, and again, a comprehensive integrated framework. We built an unusual and unprecedented coalition, and I think Betsy is going to talk about that a little bit, which include most of the largest insurers in the state, and Cameron's going to cover that too. Many consumer groups, some unions who were accepting of the coverage and financing mechanisms, business groups, local chambers, many provider groups, and a number of research and advocacy organizations. I think the imperative for reform I talked about at the beginning that compelled the governor's engagement over a year ago serves as a continued basis and resolve for moving forward. It's a recognition that inaction is unacceptable for both the insured and the uninsured alike. And I'll give a plug here for Dan's book now. Defeat is not in his vocabulary, and retreat is not in his genetic makeup. Dan's book. He intends to stay the course for comprehensive reform, and he's already begun a number of stakeholder meetings to solicit input about what is the best way to move forward for comprehensive reform. He believes the issue is too important and the crisis too serious to walk away from the progress we believe we have made during this last year. I think the reform coalitions the governor that he's able kind of put together demonstrate that traditional interests are able to step up and move a lot of the traditional comfort zones. And that's one of the things that we were, I think, had some success in doing this year, and hopefully have created a new way of looking at healthcare reform and kind of a lasting, hopefully a coalition that will have a lasting value. So you heard Peter talking about, healthcare reform is not for the faint of heart, and you all know that. And government's where the tough issues come, and certainly healthcare reform is among the toughest. But our goals remain, our commitment to the issue remains, and our resolve remains.
Good afternoon. Health reform is not for the faint-hearted. I'm here to tell you, as a veteran, Consumers Union, in fact, has been working for universal care since our founding 70 years ago. And this past year in California, we really felt that we had a historic opportunity to advance our cause. We had a Republican governor joining forces with Democratic leadership in the legislature to take a strong leadership role in comprehensive legislation for reform. And he dedicated his able staff, of which FIG is one of the main ones, 24/7, really a large team of folks in the governor's office who just hunkered down and worked for a year on figuring out the details of health reform and how to build a coalition. And we tried to do a very bold thing. It was a tall order, trying to do what no state and what the federal government has so far been able to do, fix the broken healthcare system. On the consumer side, we pulled together a coalition called It's Our Healthcare of over 100 organizations representing seniors, labor, faith-based groups, consumer groups, communities of color. And we, I think, had a pretty impressive campaign. We had a field operation, policy analysis group, and then a lobbying operation as well. And we gathered nearly 2,000 stories from consumers about their problems with the healthcare system, and were able to convey them then to the policymakers. We found common cause also with some of the business community. For example, we worked with a newly formed coalition of small businesses called Small Business Majority, and they had also prioritized health reform in California for their organization this past year. We developed an alliance as well with some of the bigger businesses and the business group on health out in California on the issue of cost containment, and worked to develop and successfully sell to policymakers a proposal to revamp the collection of data on medical outcomes and dissemination of that data, the so-called transparency package, which actually made its way into the final bill. And it's grounded on the theory that by getting that information out into the public realm, that's how improvement will happen and ultimately, in short, save money and save lives. In fact, the reform bill really had a whole constellation of cost containment features that Massachusetts didn't have, and Richard has talked about many of them: prevention, chronic care management, transparency, health IT improvements, and a public insurer option to provide cost and quality competition to private plans. And the consumer groups that classically are associated primarily with access, some of them did also make quality and cost containment a priority as well. And we saw this at Consumers Union in particular as critically important because we know that if we get expansions but don't take care of the rising healthcare costs, we'll soon be in trouble and will have sold the public a false bill of goods. So we really do feel going forward that's a national lesson as well, that we have to address the rising costs. But turning this historic opportunity, theoretical opportunity, into a viable proposal that we could support was not a simple proposition for consumer groups. And within our coalition, there were a lot of different viewpoints, and we held it together by having broad principles. But as you all know, when you get down to legislation, it's the devil in the details. We had a little challenge in our messaging because we wanted to say, yes, reform is needed and we need it now, it's urgent on the one hand. And on the other hand, we had to say, it's got to be the kind of reform that's good for consumers and that we want. So we were in this a little bit of an unusual position sometimes of accelerating, having our foot on the accelerator, and then needing to put on the brakes once in a while. When we thought it was veering off course, if the policies weren't really affordable, we didn't think they'd really be available. Other factors, of course, slow down the process too, not the least of which was the budget crisis in June. And so that stopping and starting, I think, was a little bit of a hindrance. This always happens in the policy process, but it seemed to be really kind of exacerbated this year and past year in California. So there were some key issues for consumer groups. I won't talk about them all, but just a couple in the final lap. There were really, I put them in three categories. One was the framing of the individual mandate. The second one was, if you accept that framing and you'll entertain it, then how do you assure that the policies are really available and affordable? And the third one is, okay, if you've accepted that framework, then what happens on the collection side? Because inevitably, if people haven't bought the policies, there's going to be that collection issue, which we've heard under discussion in the national debates as well. So in the big picture, we knew we needed the broad policy, the classic insurance model of spreading the risk. But the preferred framing for many consumer groups and others is really a social insurance model, which is guaranteeing health coverage in recognition of societal contributions, whether it's taxes or employer contributions. And that healthcare in that framing is really a right. It's guaranteed, it's a right, and we accept as a sort of cultural matter a shared responsibility for each other. The reform bill wasn't a social insurance model, but it did have broadly shared responsibility. So I think that both in California, what we saw happening amongst consumer groups and others, and on the national level, what we may see coming is the need to really think through how big a distinction that is. What are the fine points, and can we get our heads around this new way of thinking about things? Because it is shared responsibility, and that's really, in some ways, the same as the social insurance model. We needed to get beyond the perception that we had. The individual mandate has a punitive feel to it, that language, and I think language is going to be all important going forward. And we heard a lot about skin in the game. Consumers need to have skin in the game, and that really puts up a lot of hackles, because not only the uninsured, but those who have insurance but can't really use it or find it rescinded are feeling like they have literally their own skin and bodies in the game. So we had to get beyond some of those perceptions and some of those really sort of difficult feelings and do a close analysis of the bill, of the policies behind it, and of the likely effect. And to continually hammer away at the fact that we need to have available, affordable coverage, and it has to be meaningful and give people what they really need. And in the end, we concluded, and it was not too far from the end, that this bill taken as a whole met our standards for affordability and availability, eliminated rescissions, which we're having a huge problem with, as you'll probably have heard in California. People who think they've had coverage, they've paid for it and find it's taken away. It eliminated the exclusions for pre-existing conditions, etc. I won't go into all the details on affordability, but suffice it to say, for the very low-income people, below 250% poverty level, basically free coverage through expansion of public programs. And for those above, up to 400%, there were subsidies and tax credits that also helped with the affordability. And as the last resort safety valve, we also had the exemptions, which an agency was left to determine, sort of continuing exemptions, taking into account premium cost, how it affects ability to pay for life necessities like housing and food. And then a second category that was kind of one-shot temporary exemptions based on unexpected family circumstances or natural disasters. In California, you know, we have a lot of natural disasters between earthquakes and wildfires. So in the end, we recognized that short of the full social insurance model, we could accept the individual mandate in this bill to get the broadest pool possible and to make guaranteed issue work. With this proposal, we ended up covering anywhere from 3.5 to 5 million people, 70%, depending on the modeler that you look at, with guaranteed issue and with a form of community rating that would have made rates, we believe, affordable. Gets us to the point then, the final one about collection, that end of the individual mandate. And there was a difference that I don't think is fully understood between Massachusetts and California's proposals. In Massachusetts, if you don't buy coverage, you get a penalty through the tax system. In California, what we had was an auto-enrollment or a default system set up so that folks who didn't enroll and buy their own coverage would then be put into a plan by the state. Workability issues aside, because we never got that far, I think this was a better option. And so the good news was you'd have the coverage as a consumer. The tricky part was, again, this collection issue. We wanted to get specific collection protections written into the law, but by that time in the process, the initiative had been filed, the bill really couldn't be amended any further, so policymakers had a very practical problem. They couldn't do that. However, we were assured by the fact that the bottom line was that no collection would have been possible under the California bill until the administrative agency came back, did a report, and until the legislature took a concrete affirmative step, either by statute or through the budget, to specify what the collection would be. We knew there'd be a public process on that, and we would be there vigorously to get protections for consumers. So we come away from the past 18 months of effort in California on reform really feeling encouraged and not defeated. We got close, we learned a lot, we made new alliances, coalitions were broadened, and we're more ready than ever for the next round. If it's on the state level, if it's on the federal level, we'll be there. At the same time, we're aware that there are hurdles that any health reform is going to face in any form. So four quick lessons of the pages of them that I have that I'll leave with you. One is, everybody said it, leadership was key. Got to have a leader who's really involved, who's really invested, who really understands it, and we did have that. The second one is timing and pacing. We started out so strong with all the leaders coming out with their own plans and really sending a strong public message, and that was great. But then things dragged. The budget intervened. Things got prolonged. We went into the special session. Finally, we're at the ballot initiative. People can't amend it. The Senate felt, I think, probably slighted that they didn't have an opportunity to make their amendments. And this is such a complicated issue. The causes of the crisis are complicated. The solutions are complicated. That you need to have the timing down, the time for policymakers themselves to feel they understand what's going on, and for the public as well. The third one is trust. Trust amongst the parties is really essential. And negotiations and trade-offs have to be made all the time. Sometimes things happen in a split second, and if you don't have that underlying trust amongst the parties, as best you can get it, then someone's always going to feel like somebody else is getting away with something. How you build trust, that's a really hard one. But one way to improve it, I think, is to have a really open process. I think we did pretty well on that, but again, timing was tricky, and so going forward, openness of the process will be important. And the fourth thing is open-ended language problem. Delegating details to an agency is probably going to be essential, whatever agency, on the federal or the state level. And yet, when we don't have things spelled out really clearly, fear takes hold. And so to find that balance is going to be really tricky, to have enough specificity so that everybody can feel comfortable with big changes, but not so much that you get bogged down and locked in where you shouldn't. So we hope this is the beginning of a robust dialogue, a public conversation on health reform, and then we can contribute our lessons from California and actively participate. Thanks.
Well, I'm going to try to wrap up here and be fairly brief so we can get to your questions and discussion, which I suspect will be robust. For many of you who have been working for healthcare reform, the failure of yet one more attempt, even in a state as big as California, may not seem all that surprising. But it really should be kind of shocking, actually, that this bill failed. If you think about it, you had a Republican governor who was endorsing billions of dollars in tax increases and a method to bring $4 or $5 billion of new federal money to his state. You have the Democratic Speaker of one house of the legislature fully supportive of the plan. You have the state's hospitals not only willing to be taxed, but actively supporting a tax on their revenues. You had most of the state's largest insurance companies supporting strong new regulations on their practices. And you had more than a handful of large employers supporting an employer mandate, and consumer and labor groups supporting an individual mandate and the rest of the package. But somehow this thing still could not pass in the California legislature. Now, why is that? It's, conventional wisdom is that this is an example of the failure of Schwarzenegger's idea of post-partisanship, of trying to work across party lines to get things done. And of course, it is. But in another way, it's also a confirmation of everything he's been saying about the California legislature, much of which also applies to Congress and the politics of many other states. And that is that the polarization of our politics today has become so destructive and is so divided the left and the right that there's hardly any room left in the middle for people to push through pragmatic solutions. So in California, the plan suffered from polarization, suffers from some personality dysfunctions within the players, particularly in the legislature, and I think it suffered a little bit from the process that was used. So the 3 Ps. And I want to start with a 4th P, polling. As I think Richard mentioned very briefly, it should not be overlooked. The governor's plan was supported, all public opinion polling that was done on this from the very beginning to the very end showed that somewhere between 60 and 70% of Californians supported this plan, even when it was explicitly described with the tax increases, the mandates, individual responsibility. So you have overwhelming public support for the concept. That support clearly would have dropped in the midst of a tough-fought ballot measure campaign, but it was started from a very high level of support. Yet he could not get a single member of the legislature to carry his bill. Richard might say, well, they didn't really care if anybody carried the actual bill because they were going to do these stakeholder negotiations and the whole thing was going to evolve.
That's what I say.
But we know from the votes that went up on the bill eventually that, for starters, not a single Republican in the legislature supported it. Republicans en masse in the legislature in California would not support anything that included new revenues. They would not support anything that included any mandates on anybody, and they wouldn't support anything that included any new regulations on the insurance industry. So that kind of made it difficult for them to support this plan or anything resembling it. So what that did was force the governor to rely entirely on the Democrats. The Democrats, meanwhile, their hearts in California, as in many other places, are really behind single payer. They've been trying for more than a decade to find a way to create a single payer plan in California. It's been on the ballot, it failed. It's been in the legislature. It passed without revenues to support it. The governor vetoed that. They really want single payer. The leadership was willing to stipulate that that wasn't going to happen, so they would talk to the governor about some other kind of plan. But if they weren't going to get single payer, their ideal was an employer mandate. They felt that forget all these other people, shared responsibility, and make the employers do it. Well, they had tried that a few years ago, and that bill, having been passed by the legislature and signed by the previous governor, was effectively repealed by the people in a referendum. And this governor said he wasn't going to do that all over again. And so their second choice for the Democrats was an employer mandate. They also wanted much stronger regulation of the insurance industry. They wanted rate regulation and other regulations of the insurance industry. And they were pretty much opposed at the beginning to an individual mandate. So the governor really had to work with them to overcome a lot of the differences that he had with the Democrats. If the Republicans had actually been at the table and part of those negotiations, it's at least possible that the Democrats would have felt compelled to come a little bit more to the center in acknowledgement of Republican support for some of the things that they traditionally had opposed. But with zero Republican support, the debate really became kind of an intramural debate among Democrats, with the governor off to the side as, pull it the prof now, as a party of one. And so the Democrats were led by Assembly Speaker Fabian Núñez from Los Angeles and the Senate Leader Don Parada of Oakland. Unfortunately for the governor and probably for the people of California, these two guys really don't like each other. They are political rivals, they are personal rivals. Nobody seems to know exactly how this evolved or why it got to this level. There's always a little bit of tension between the Assembly and Senate leaders, as there probably is here between the House Speaker and the Senate leadership. But in California, it just became incredibly destructive and personal. I mean, much of the time, these two guys don't even talk to each other. It was difficult for the governor to get them in the same room for joint negotiations. Their staff were okay. In fact, the Senate staff was involved in most of the stakeholder negotiations and meetings that went on behind closed doors. But publicly, the Senate leader, Don Parada, distanced himself from the entire affair and announced very early on that he was going to focus on another big complex issue in California, water supply and water storage, while leaving to Núñez the negotiations over health care. But he was kind of passive-aggressive about it. After announcing that he was going to leave it to Núñez, he then sort of griped and complained and whined when he wasn't in the loop on every turn of the wheel. So they could never really quite figure out what was going on with the Senate leader. And the effect that had was that his members never had buy-in. And so after the bill passed in the Assembly, they needed to make a big push in the Senate, and when interest groups started pushing back, the senators, who had not really been kept in the loop and were not part of the negotiations, even though they could have been, since the staff was there and it wasn't exactly secret what was going on, but they just weren't really engaged on a gut level or an intellectual level. They just didn't have that buy-in. So when the going got tough, it was very easy for them to just kind of bail out. So I think that personality split really was probably more important than all these other things we've been talking about, because if the Senate leader, Senator Parada, had been in on this from the beginning, if he had been personally engaged and excited about this idea, then the timeline that people talked about would have been accelerated. The issues that have been raised by the legislative analyst and others, the problems with the bill, could have been aired and settled earlier. They're all fixable. They wouldn't have been up against this January timeline. All of that flowed from, I think, from the Senate leaders distancing himself from the bill. And then finally, on the process, it was a strange process. As I said, the governor's bill was never introduced in the legislature, and so you just kind of had this amorphous discussion of an outline. There was a Democratic bill, which they eventually sent to the governor's desk in the regular session, which ended in September of 2007, knowing that he was going to veto it. It was just a symbolic passage to, I guess, satisfy their interest group supporters. The real negotiations, which were going on behind closed doors, were where the action was. And they weren't exactly secret. I mean, the public wasn't in the room when Richard was in there with hospital administrators or insurance company executives. And everything they did was eventually made public. But I think if they had made that process more public, as soon as they had reached an agreement or a tentative agreement, if they had rolled it out and had extensive public committee hearings all through the year as these things were developing, then I think, despite Senator Parada's distancing, even his own membership would have been a little bit more informed, the press would have been more informed, and the public would have been more informed about what was going on. I mean, the fact that the hospitals supported attacks on their revenues should have been major news, but it was hardly a blip in the California press because it just kind of leaked out, you know, in this amorphous fashion. The fact that insurance companies were supporting rules requiring them to provide health insurance to everybody, regardless of pre-existing conditions, could have been big news if it had been vetted in this kind of an open hearing process. It wasn't. The details of the individual mandate, the employer mandate, these are big, complex issues that people need time to kind of chew on and understand. And even though there was all kinds of time, there didn't seem to be much motivation on the part of the players involved to really roll that stuff out and bring the spotlight to it. They kept wanting to wait until they had the whole deal so that they could present it and then move it through the legislature quickly. But unfortunately that happened too late in the game, and then it ended up being creating a backlash. And much to my surprise, because I was following this stuff fairly closely, many of my colleagues in the press described this as a deal that was hatched at the last minute. We're saying, you know, a last minute deal. Well, it had been hatched over 12 months, and much of it had been nailed down months and months before the final vote. But I can understand if you weren't following it closely, you know, you might get the impression that it was a last minute deal. A few of the final details were hammered out, you know, within 48 hours of it going to an assembly vote, but that was like 2% of what was in this bill. So those are my thoughts on why it went down: polarization, personalities, and process. And most of those things, I think, are, well, the personalities will change. The process is correctable. I think it's going to take a while to see if the current polarization will change either in California or in the national situation. All right, thank you very much.
Thank you so much to all the panelists. We have about 15 minutes for questions, and I know that some of the folks in the panel probably would like to speak back to one another, but I'm going to turn directly to the audience for your questions and hope that the panelists will weave those things into their answers. Yes, right here.
Sarah Thomas with AARP. I'm interested that you this question's for Betsy, that you felt that the package in the end of the day was affordable. What about it made it affordable? What was your rule of thumb?
Hello? Okay, it works. You know, this is the $64,000 question. What is affordable? And we batted around internally in our own organization and with AARP out in California as well during this whole debate. There's been some research done. What do people actually spend? What do employers actually contribute? Trying to get that data. And frankly, I think we have more to do on that as we go forward in the national debate or in California. I think we have more data to be gathered and studying to be done. So we just looked at and made our best back of the envelope calculation based on what people are paying. They're paying a lot more than 5%, those that are paying. So that, but we did just deal with premium. So we know that the out-of-pocket costs are very, very important as well, deductibles, copays, all that. I think we just need a lot more policy work done on it. We just kind of looked at what we knew people were paying and gave it our best shot.
Great. If people could go to the mic, I guess that's what the, or if we have a roving mic.
Right here, we don't.
We don't. Okay.
Ed Berger, there's been no discussion in the crafting of the program of dissociating employment from insurance. Was there any, and if there was not, why not?
I guess I could try to tackle that one a little bit. I think what we had proposed, and we proposed an individual mandate, non-employer mandate. I think that remained true throughout. There are those that would disagree just because we did have a minimum employer contribution if you didn't offer coverage. But as many have noted, that minimum contribution was a lot less than the percentage of their income or resources had they gone out and purchased it on their own. So I think we approached it from one point of view of an individual mandate, individual responsibility, but knowing at the same time that we didn't want to lose the large amount of employer contribution that was currently out there. We didn't want it to erode in favor of more government direct subsidy, and at the same time didn't want directly to impose a pay-or-play kind of environment where you either purchase coverage for your employees or pay an exact equal amount into a purchasing pool. We had used other subsidy mechanisms to lower the employer contribution. So we did approach with an individual mandate, but again had to recognize that most of the dollars in the system other than the government are employer dollars, and we didn't want to lose a lot of that money. So our notion of shared responsibility included some employer contribution without imposing a direct mandate that they either purchase it or spend an equal amount and give it to the state instead. So it was a tough, very tough issue, and as Dan and others have noted, over time, because of the negotiations that went on, the employer contribution did go up over time. We had a little different system, particularly for very small employers where they make no contribution at all. But for a variety of reasons, in the politics of trying to get to yes, and get our coalition of the willing together, or whatever you want to call it, that employer contribution did get larger over time. So one, obviously there are certain people making the argument we were closer to the employer mandate at the end than we were at the beginning. But again, we kind of stuck with the personal responsibility mantra throughout and tried to overlay that with kind of the shared responsibility for financing.
I just would add, amplify that in California, the Democrats, other than a single payer plan, will not entertain any plan that quote unquote lets employers off the hook. They are very close to organized labor in the legislature, and for labor they just believe that this is an employer responsibility and you cannot talk to them about economics and pass-throughs and the fact that employees end up paying for it anyway. They just see it's almost a symbolic thing that employers must be made to provide this benefit and manage it for them, and you just cannot even begin a conversation otherwise unless you were going to go to a full single-payer government plan.
I believe just two quick things. In terms of the employer mandate piece of the employer role, I think one of the reasons you see it discussed nationally is really the idea that that's how most people get insurance today. And when you start talking about breaking that link, and there are certain reasons to talk about it, but when you talk about breaking that link, you're really talking about having everyone with their health insurance today start to do something different. And that kind of disruption, I think, is problematic. One other point that's worth mentioning quickly on the employer mandate is simply that many employers in California who supported the notion of that there should be a fee. There should be a fee for non-offering employers to put in, and it really stems from, I think, an understanding that's really growing in the employer community that those who are offering insurance really are subsidizing their competitors who are not. And so I think you'll start to see that as a key issue at the national level.
Okay.
Hi, Kate Stedman from the Kaiser Family Foundation. So you mentioned that polls show public support was very high for this, and you all sound very, optimistic about chances for health reform in California in the future. But I'm wondering, what is the public saying now in the wake of this? Does it seem like there's any accountability for the legislature? Do they want to try this again, or did everything kind of go over their heads? So I'd just like to get your sense of what the public thinks now.
Speaking for the public, I have no idea what the public thinks right now. All I can tell you is that I think everybody who participated in this is what the governor called it regrouping. We're all regrouping still, I think, and trying to figure out, given the growing budget deficit, what can we do going forward? We think that the proposal still is a very viable one, and maybe even more important because of the deficit problems that would have brought in new money. But that's not the spin that the public, I think, has been getting. So I think to the extent people are watching this, I think there's confusion and there's fear about this huge budget crisis in California. What we've said to the governor and others is, keep the bold vision thing, keep the conversation going, keep the drumbeat going. Let's make a plan. You've got 3 more years. And let's parse it out over the next 3 years. Let's think of the things that we can do to get California ready and to get us closer, because we started from way behind the curve. Massachusetts had guaranteed had a lot of better features than we currently have in California. We could organize our marketplace, do things that won't cost any money this year, and then see what other pieces we can put in place to go forward. That's our hope. I'm not sure about the public.
John?
John Rother with ARP, and I want to make clear that ARP was strongly supportive of this effort and worked very hard, and we were very disappointed. But what strikes me about your presentations as a whole is what was not mentioned. There was no mention of ERISA or Medicare, or even the fact that health reform is actually being debated now at the national level, and one could imagine, at least for Democrats, that they might prefer to wait and have Washington deal with this rather than make the tough trade-offs in Sacramento. So I wondered if you could just comment on those beyond California factors and how powerful, or why, if they weren't powerful, why they were disregarded.
I can try. I just have a couple of thoughts on that, I guess. And I think, we always knew ERISA, our cousin ERISA, ERISA. We always knew our cousin ERISA was somewhere around. I think that both the legislature and governors, viewpoints was that we had tried to structure this in a way to not run afoul of ERISA, at the same time understanding that whatever we tried to do might eventually be tested in the courts and might, depending on what happened, might very clearly put it back on the federal government in terms of trying to allow states some experimentation or do something at the federal level. So, it was always a gorilla behind the door. There were several gorillas behind the door, but that was one of the gorillas that was behind the door. But it was actually pretty close to the top of our thoughts, and we tried to employ through a number of entities some expert opinions and expert people that really knew ERISA law to help us kind of wade through things so it wouldn't be a real prima facie violation of ERISA. So I mean, it was always there, and it wasn't really ignored, but we didn't spend a whole lot of public time debating that part of it, because I think we tried to really focus on how do we make this, never make something ERISA-proof necessarily, but try to work through some of those issues.
If I could follow up just briefly, one could imagine, given a very uncertain outcome in November with regard to a referendum, that at least Democrats at the national level might want not to take that risk. And I wondered if there was any kind of dialogue between the state and national leadership about whether to go forward in California.
It wouldn't occur at the governor's level.
I guess a couple quick thoughts. On the original question, the problems that might be posed by the federal government, ERISA was certainly one. The plan also caused for, as I had mentioned, expanding our SCHIP program at a time when President Bush had vetoed it twice. So there are questions about whether or not the federal funding would be available that was being called for. And I think the attitude that at least the supporters took, and there was much debate about this, the supporters took was, we need to be aware of what's going on at the federal level, we need to understand what's going on at the federal level, but we can't wait, and we shouldn't wait, and we shouldn't delay, and so, just keep pushing forward. And I think that is most likely the right approach for states to take, that you shouldn't wait to see what's going to happen here in the Capitol. In terms of the second question, having done some work at the national level, the folks I would interact with, I think we're all very interested in California being successful in the hopes that it would build momentum, that would push reform forward, that it would be an example of what can go right, building on Massachusetts, and to take that momentum into 2009. So my sense of it, at least just from my perspective and other people who may have, is that there's a lot of support from people in DC, like ARP, like SEIU, like other very critical players who wanted to see California go forward, and in fact still want to see California go forward.
We're running out of time, so we can just do these as quickly as possible.
Question. I wanted to explore some of the assumptions about access that may have been used in numbers. The presumption has been throughout the dialogue that insurance equals access, and even assuming that the primary care physicians, the 2% tax on physician practices persists with the thing,
No.
I got wiped out, okay. But my other assumption is that the level of benefits would be kind of at a Medi-Cal, S-CHIP, Medicaid kind of level. Is that true? At a time when you have a declining number of physicians in California, many of them are stopping to accept Medicare, that assumption is really very problematic. In other words, I'm sure you have a political victory, everybody has insurance, let's go home and wipe it, but putting 10 million or 47 million people onto the market when there aren't physicians able to see them at a level their practice can afford. Even if they can, they don't have the aggregate numbers. Is kind of vaporware.
Well, I'll just make a couple comments about that. That was an issue that people did bring up. It's like, all of a sudden you can put 5 more million people into kind of a primary care physician relationship. I think that we believe that physicians are seeing a lot of those folks. It's probably in the most inappropriate setting. It's probably in emergency rooms or very episodic, so it wasn't like they were nowhere in the system. I think that we wanted to err on the side of giving them a more of a medical home kind of situation than they currently have right now. Folks said we didn't do enough on the healthcare workforce stuff, and we probably do need to do more work for that. But when you take a look at how long it takes to establish, the pipeline for more physicians, we'll be talking about this 10 years from now instead of now. So I think we do understand the issue about insurance, equals access. One of the things we really tried to do in here is increase Medicaid rates. To get them to Medicare rates, understanding that there are issues out there with Medicare rates.
Even Medicare rates are not adequate.
True, but believe me, given where we are on our Medicaid reimbursement, getting to 80 or 100% of Medicare is huge. Right. So I think that we thought, that knowing, if a physician is looking to relocate their practice or establish a practice in California, knowing that there's an expectation of a culture of coverage, and when someone comes in their door, there will be a reimbursement stream, and then we're paying them a lot better. It's kind of if we build it, they will come, but also understanding that those folks, whether formally or informally, do have some relationship with the healthcare system in some way, and trying to focus that more on inappropriate settings to more appropriate settings.
Last 3 questions, we're in the lightning round now.
Bob Rosenblatt, freelance writer. I'd like to ask the panel specifically what they think the role of the Republican Party will be in California. Do you think that the next time around the governor can get members of his party to support his reform? And then the context for the national discussion, if you speak to the domestic affairs people for the McCain campaign, they say they are very eager to run against what they call Hillary Care or Obamacare. The Senator McCain wants an expansion of health savings accounts and possibly a cash out of the employer's share, giving it to people, and then they go on their own. So that seems to be a very different approach than what's been tried in California. So A, will you be able to get any Republicans the next time around? And B, what consequence does this have for the national debate?
Dan, you want to?
If the plan includes revenues, mandates, or regulations, no. There will be no Republican support for it in California. On the national level, I think it's too early to tell how that issue is going to cut, but my gut tells me it's still with the Democrats. I think no matter what kind of intellectual argument you can make for the kind of things you mentioned on McCain, I think this is more of a gut level issue right now, and people hear, we're going to cash out the employer contribution and have everybody buy it on their own. I think the Democrats can capitalize on that and make the middle class will conclude that they're going to be literally on their own, and most of them don't want to be there. So I don't think that's going to work for McCain.
Hi, I'm Ann Kemsky with SEIU, and I want to reiterate John's comment that we are just part of our coalitions, and as SEIU, we very much supported the California reform, and we applaud everybody here who had showed so much leadership. I wanted to just make a comment about a lesson learned that I didn't quite hear, but this lack of enthusiasm at the end for the deal. I mean, I don't think that this deal died because it didn't have Republican support. I think this deal died because it didn't have enough enthusiasm from its supporters once all the compromises had to be made. And I wondered if you could comment on sort of what could be done. Is there anything that can be done about that?
It's a really good point. I mean, just by what we've been calling it today, the compromise bill, people don't feel as excited about a compromise as they do about something that they've got a religious, fervor about, and it's everything that they wanted. So I think it was difficult, and I think it was an issue. And I think that because of the pacing of things and the way that it kind of unfolded relatively slowly, we didn't have the chance to get enthused enough to appreciate how all the pieces would work together. And so again, that goes back to that timing question. The sooner we can get it settled, and then we can really, everybody can dig in, understand it, and act more enthusiastically.
And last question.
Quickly. I'm Jerry Fairbrother. I'm with the University of Cincinnati Children's, but I do a good bit of work with California Endowment. And my question is, say it had passed, and say hard economic times had come. Do you think that some kind of restructuring of the Medicaid formula needs to happen? I mean, when hard times come, people, employer insurance erodes, more people are on the public, and in response to hard times, as you know, California, the governor has gone to quarterly renewal for Medicaid, which is in an attempt to, and it will lower the budget, have more people off and lower the budget. And do you think some kind of, and I realize you can only slay so many dragons in a day, but do you think some kind of restructuring of federal support so that when economic times are bad, federal funds come in and supplement states?
Amen.
Yeah. In the spirit of the lightning round, yes. Clearly, there needs to be more attention paid to the safety net, not just in difficult economic times as we are now and will continue to be in, but even if the program was functioning normally and the economy was great this year, we would still likely have, I think, this initiative from the Bush administration that looks at reducing support for Medicaid. And so California continues to need to figure out how to do better to bring in more federal dollars as is appropriate under the law. The federal government also needs to make its commitment clear so states know what to expect, and so that the partnership that is Medicaid and S-CHIP really is in place when it's most needed in bad economic times.
Thanks so much to all the panelists, and we're going to go right on directly to the second panel. The conclusion of this one, you heard the lessons from Betsy, but the center existed and held, but it wasn't quite broad enough and didn't hold long enough, and how can we do it the next time? Thanks so much.
Okay, I'm going to jump right in and do the introductions very quickly because you can see why we brought these people here. We've got another exciting panel and I want to continue this dialogue. Beginning, we'll start with Patricia Lynch, who is officially the Director of State Government Relations at Kaiser Permanente, but that grossly understates her role. She was described to me as a woman who played, I believe the correct word was managing general of the Kaiser effort, which tried really hard in 14 different ways, along with AARP and SEIU and others, to try to make this happen. And so Patricia's going to talk about it from the Kaiser perspective, but also take us a little bit to Kaiser National and thinking about this national debate. Then Crystal Haley, who is, as I said before, in addition to being president and CEO of Blue Shield Foundation in California, she is a catalyst for change in California, and she worked very hard to not only support the development of policy and ideas, but also communication and coalition building. And she was involved in a lot of different coalitions with foundations and others to try to take the message broadly, and I think you're going to learn a lot from Crystal. And finally, Michael Shaw, who is the legislative director of the NFIB California, and I think it's fair to say we all owe Michael a great special debt of gratitude to be willing to come up and explain why they opposed the bill, but I urge you seriously to listen carefully, because if we're going to move this conversation forward, we're going to need to be very mindful of exactly what the contours of the opposition were, and I think you're going to hear some things about NFIB principles as they evolve that suggest an avenue where we might move forward as a nation, and that is indeed the goal. So, Patricia.
Thank you, Wes. Thank you, and I appreciate being invited here today. I want to say first that Kaiser Permanente has for a very long time supported universal coverage at the national level. In fact, Henry J. Kaiser, our founder with Sidney J. Garfield, the first Permanente medical group, tried to talk FDR into incorporating national health coverage into the New Deal, but he thought it was too difficult. He wanted to work on Social Security. So that's how bad. The governor's proposal was extremely comprehensive. I think that's been said by other people here, but I want to repeat it. That it dealt not only with coverage, which was a combination of an expansion of private coverage and publicly subsidized coverage, but it also addressed delivery system reform. It had scope of practice changes, it had incentives to do health information technology, it had a lot of exciting potential delivery system reform, and it identified the financing that would support both. Now, KP recognized immediately that this was a very exciting possibility within the state of California to move health reform forward. And we did consider the ERISA issues, but as Richard said, we talked a lot about how we could do it within California, but we also thought it was important to get something on the books that would be a model for other states and for the nation. We also saw that there was going to be some difficulty in designing the market reforms in a way that would preserve comprehensive coverage. We had always, we support market-based reform, though we support universal coverage, period, and we prefer market-based reform. But we realized as we looked at this that even there, that there was going to be potentially some adverse, so to the extent that we were not going to establish one uniform benefit package, which was not on the books. The governor had an initial benefit package with a $5,000 deductible, and there would be other packages available in the market. We understood that in order to protect the affordability of very comprehensive packages, when there was still going to be offered a very affordable, high deductible plan that would probably be most attractive to healthy young people, we needed to get some rules to govern that. And we reached out to our sister health plans. Blue Shield, Bruce Badakin, has been an outspoken proponent of universal coverage for several years, and HealthNet, Jay Gallard, another proponent of universal coverage. And we worked some very detailed rules around the individual market that established 5 levels of benefits that started from a more affordable, high deductible plan to a higher comprehensive plan, and would require that the rating between those be connected, so that plans couldn't gain by having a very expensive, by pricing the expensive ones so that it would be unaffordable, and pricing the low benefit ones so they would get all the young and healthies. We worked together. Ultimately, we reached out to other health plans, Cigna, Aetna, and Pacific Care, who all agreed that the existing pattern in the individual market, particularly, of competing by avoiding risk was not only unacceptable, it was not sustainable. And we could establish some good, solid market rules that would allow for a differentiation in the market so that people could choose the level of benefit they needed and wanted, since that was, since standardization was really not on the table. But would also begin to move the plans to compete based on both quality and access and affordability, but not based on ability to avoid risk. And we think that was one of the biggest contributions that was offered by the plans to the health reform debate, short of just the fact that for the first time, 6 major plans supported guaranteed issue. The other thing that I think we learned quickly was that, we at Kaiser Permanente know the true affordability in the healthcare delivery system, for health coverage, is only going to come when you address delivery system reform. And the governor tried to do that, but the reaction of providers was pretty quick and pretty extreme. And so the delivery system reform pieces became placeholders. And what we really believe is if you can deal with the coverage issues, which in fact are easier than the delivery system issues because that's just money, you will create an environment where you then can begin to get the kind of quality, transparency, reporting, the things you need to do to begin to address the very serious issues that are in the American delivery system right now. We also think that it was a very good learning experience to have the disparate stakeholders supportive of reform sit down and talk to each other. In fact, in the process, a lot of trust developed. And we had learnings not only of what the consumers' needs were, and SEIU's needs, labor's needs, and the providers' needs, those providers that were sitting with us. But what we learned, our own tolerances and our own needs in a universal coverage environment, in a reform system. And I'm hopeful that as the discussion moves forward, that we aren't going to start from the beginning, that those learnings from people, many of whom are in the national stage right now and will be in national discussions, will be moved into those discussions and will continue over the next several years. I think for purposes of time, I will cut short my remarks, but I look forward to all your questions, and I want to thank you for inviting me.
Hi, I'm Crystal Haley with the Blue Shield of California Foundation. I'm just going to spend a few minutes talking about the philanthropic response and the role that foundations played in California. A lot of people will say that there are a number of things foundations can do, that they provide the research and development, kind of the R&D, the glue that kind of helps to move processes forwards. We certainly think that as a foundation, the Blue Shield Foundation, which is a private foundation which does about $30 million in grant making in California, that one of the things that we are is a catalyst to try to actually put policy issues up forefront and try and find ways to support people who can actually move that process forward. And we certainly also consider that another thing that foundations can do is to really act as, find a way to help create a megaphone for those populations that don't actually normally get their voices heard in the normal process of policy conversations. I think that we saw that the foundations in California did all three of those things, and I want to talk about the philanthropic response and the role that foundations can play, because I think it has an impact at the national level as well. One of the things that we saw was the foundations, one of the things we did was, we were all there in July of 2006 when the governor convened a health policy framework conversation. He had 50 sort of stakeholder groups come together at UCLA for one full day meeting in which the governor sat there for the whole day and listened to all those stakeholders talk about what needed to happen around health reform. That was a real seminal moment because it certainly became clear to most of us in the philanthropic community that the governor was really serious about taking on this issue and was going to demonstrate some real leadership. I think at that point, you saw many of the foundation leaders, some of us said, well, we need to have a unified response. It may not be clear to all of you all, but foundations aren't always a unified voice, don't always share the same opinion about what needs to happen. And what we decided to do was the largest foundation, health foundation in the state, which was ourselves, California Endowment, California Wellness Foundation, and the California Healthcare Foundation, decided to have phone conversations, the CEOs decided to have phone conversations once every couple, 2-3 weeks, during which we were trying to update each other on the process of what was going to be happening in health reform. I think that was really critical because many of these foundations fund some of the key groups that are going to be having a role in the conversation. For example, California Endowment did some really important work early on that was around framing the whole conversation. One of the things we learned was that people in California weren't particularly interested in talking about covering the uninsured. People were talking about fixing the broken healthcare system. That's a really important frame, and one that we saw played out in the conversation in California, and I think it led to why 50, 60, 70% of the people in California were actually supportive of the idea of what the governor was putting forward. Another thing that we saw was that it was really important to have some data that people could agree upon. California Healthcare Foundation funded John Gruber to do some of the modeling. And one of the things that all of us agreed to as foundations were we weren't all going to fund different groups to do the modeling. Part of what happens when you're going to have a very complex policy conversation is that you get into dueling models. Well, our model looks better than yours, and these numbers are more right than your numbers. It was really important, we thought, to at least try and agree to have one group, one set of numbers, so that we were talking about the policy issues. No one set of numbers were going to be perfect, but it was important for us not to be out there as funders funding kind of differing things that were really fundamentally really not going to be about the issues themselves, but were really just going to be about, my policy wonks smarter than your policy wonks. So I think that was really important. It was also something that we talked about around the whole question of how could the foundations support a policy process. Now, one thing I will say is, one thing you can say about Governor Schwarzenegger is that he's not a big process guy. This, I think, was one of the challenges that we ultimately did have in California, was that there were private conversations, which, as we heard, they weren't secret conversations. But understanding what that public conversation was that was moving forward was really challenging. One of the things that we did was in the spring of last year, all the foundations came together and decided that we were really concerned that there was going to be a deal struck around health reform. We had an idea in our mind where that deal was going to happen. It was probably going to be in the state capitol, well, maybe not in the capitol, but in a smoking tent outside of the capitol. And that was where the whole deal was going to get cut. And how are we going to bring the voices of everyday Californians to that table when that deal was getting cut? So one of the things that we did was we funded a project called California Speaks. This had never been done before. It was 3 foundations came together and put the resources in to make, in a very short amount of time, happen an 8-site, one-day conversation that lasted 8.5 hours with Californians, 3,500 Californians from around the state that got together to talk about health reform. And that conversation was really unprecedented. We had the governor, we had the speaker, we had the head of the Senate, we had some Republicans. In all of those sites, they were video linked, had people coming together to talk about health reform. These people were not there representing constituency groups, and I think this is really important. They were random digit dialed invitations. So this is truly a cross-section of Californians. And I think the organization, by the time they got to it, had done 2 million phone calls inviting random folks from California to come out. And they did come out, and they talked about the issue and demonstrated to us how important it was for them. One of the key findings from that was to really point out that Californians were much less ideological about the solution to health reform than the leadership was. They really felt that there were options out there on the table, as long as we were taking some serious concerted steps to look at fixing the system, bringing in the dollars necessary to do it, and being reasonable and thoughtful in the process. There were a lot of options that they were open to. Finally, I think that really does raise the question of how we utilize philanthropic dollars to continue to focus the responsibility and the support for this conversation going forward. One thing that we know is that the polling process will give politicians a reason to do something if they want to, but polling doesn't hold them accountable for doing things they may not want to because they're unpopular. And so there has to be some other way that we bring the public into this conversation over an ongoing basis to begin to really figure out how we create some accountability in the system. I want to just close with the concept that I have been sort of holding, and I think a lot of us in the foundation community have been trying to struggle with. There are, one thing that we did have in California was some real leadership around this issue. But there are 2 conflicting visions of what leadership really is. One is that leaders create vision and then people move towards that vision. And one is another idea that I find very interesting, which is that leadership is the process of disappointing your constituency at a rate they can handle. And I think that there's some real truth to that. And one of the things that we really saw was that in California, timing made it difficult for people to do that. Once you got leaders to actually sit at a table and be willing to negotiate a second best option that wasn't the one that they had been really convinced and talking with their constituents about for a long time, those people then needed time to go back and sell it to their constituency group. And that takes time. It takes the will for those leaders to do it, and we saw we had to really push some of those folks to be willing to do that, but it takes time to do it because what people were trying to sell in the compromise bill back to their constituency groups was not anything that any of those constituency groups had heretofore supported as an idea. So that's a really important piece. So in closing, I just want to say that one of the real tasks we struggle with is that coalitions, and a coalition I think was created in California around this, have to always be mission-driven. Unfortunately, negotiations are typically task-driven, so we've got to find a way to hold that and figure out how to really move forward with this. But I think in California, the lesson is there are opportunities for philanthropic organizations, if they come together, to be real catalysts for this change, to provide some framing conversation for this work, and to be real partners for those of you who are really driving the policy conversation to figure out how we push it forward.
Thank you all for the opportunity to be here, and particularly for Len and the New America Foundation for inviting me to come out here. However, I'm a little disappointed. You promised me bulletproof glass. But we'll let that go, as long as everybody promises to be careful. I wanted to start out by saying there's obviously been a lot of talk about healthcare reform and what it means and what the struggles are that everybody deals with, but I want to keep the focus on small business a little bit here for a moment and say small businesses live the struggles that we're talking about with healthcare reform, healthcare insurance. So it's not that they're the bad guys. It's not that they're out there trying to keep people from having insurance. They're actually doing the best that they can to provide those benefits, but the struggles, the costs, and so on and so forth, the things that we've talked a lot about today and we'll continue to talk about, I'm sure, for at least the next several years, are the things that they're dealing with on a daily basis. I wanted to start out with a little bit about our perspective on what happened in California. We've heard a lot about the reasons why things didn't ultimately produce a product that became law. But I want to talk about a little bit from the small business perspective. And then also, as an organization, NFIB has taken out with a set of principles that we're supporting. They're really 40,000-foot principles, so don't expect me to give you the details on every little piece. But we were actually taking steps beyond that I'll refer to help better define what those principles are and how we're going to put them into practice. In California, obviously, we had a very significant effort, and I think Richard Figueroa from the governor's office and the rest of the team, in addition to the governor, deserve a significant amount of credit for the work that they did and the amount of time that they did, because it is and remains a gargantuan task. However, when we look at the issue of what was actually composed of that reform, we see that there are a number of different pieces, all of which in and of themselves are pretty significant changes in the health insurance market, health reforms. I want to talk a few about some of the positive ones, and then also about some of the ones that we weren't the biggest fans of, and then kind of give you the overall perspective. On the positive side, because I was told, you really need to say something nice first. So you bring people up and then you bring them back down. The transparency push that the governor had from his initial plan, which is the infamous 10-pager, for anybody who's familiar with the details of what went on out there. From the beginning to the end, the governor was big about transparency, how that was necessary to help educate everyone involved in the system and make that possible through the availability of that cost and quality and outcome information was really critical. The pooling, that certainly helped provide an opportunity for those who were otherwise unable to get insurance to do so through the pool. And also the products focusing on prevention and wellness are certainly big, significant steps that need to be a part of whatever healthcare reform goes forward. Penny wise, pound foolish. I mean, you save a penny today, dollar tomorrow. There's lots of different ways to cut that up. But if you can head off problems, obviously you're going to save a lot more money down the road. There were, however, a number of different factors that we, as an organization, NFIB, representing about 22,000 small businesses in the state of California and about 350,000 members nationwide, weren't the biggest fans of, not the least of which is the fact that it had an employer mandate. And I know we've heard a little bit of discussion in the first panel about whether or not it really was an employer mandate. There's a bit of potato going on there, but the fact of the matter is employers were going to have to pay, and our members see that as a mandate. So the mandate was certainly something that they struggled with, and obviously it started out and moved around all over the place, and AB 8, which was the speaker's earlier proposal that was referred to had a much higher tax rate than even it ended up being in the end. But that nonetheless, our members have continually told us that mandates are not acceptable in this area, that employer taxes, which many economists agree are probably the worst way to do this, to fund healthcare, were not going to be acceptable to them. It also, we believe, missed the mark on affordability. And really what I mean here is it didn't really address the issues of affordability. It talked a lot about coverage. It talked a lot about a few things like maybe health IT and some prevention and wellness that have some good long-term prospects for saving dollars in the healthcare system, but it really didn't address the here and now. And we think that was one of the major shortcomings of the governor's, the ultimate compromise bill, we'll call it. That was definitely an area where we believe it fell short. The funding also probably would have left the system underfunded. As the Legislative Analyst's Office, I think it was referenced earlier, said that it would be about 5 years out, roughly $1.5 billion underfunded. Well, in California, obviously that's a significant amount of money, and our members, being the skeptics of most government that they are, felt that this would ultimately fall back on them, either through an increased payroll tax or through some other tax rates that would have to be increased to help bolster the state's general fund, because in that situation, as the legislative analyst said, the state would be left holding the bag. So we believe that all of those things really led to a situation in which this was an untenable prospect for small business owners, particularly in the 21st century economy, where you have jobs that are able to move across state lines, across countries. You have people who can work just about anywhere doing many jobs. But particularly when you're talking about the small businesses where you can't do those types of things, the restaurants, the dry cleaners, the businesses that are stuck in a brick and mortar location and have to provide a service to a clientele from that area, you put an undue burden on them. They're forced to go out of business. They don't have that many choices. How did, so there are these good and these bad things in the governor's and the speaker's compromise bill. How did small business see this? If you're a fan of Princess Bride, you could refer to it as the bottomless pit of despair. However, I prefer the Armageddon analogy. The Bruce Willis movie where the asteroids coming to destroy the Earth. Just to clarify, because there are only a few of those. The analogy is, tell me what is one of the characters, and I forget the names here, but one of the characters is asking, what's it going to be like up there on the asteroid when we're doing all this drilling and everything? And the guy runs through this list of things, and it's like, it's 500 degrees in the sun, and it's like 250 degrees below zero, and in the shade, and exploding gases and rock and all this stuff. He says, oh no, he said, wait. All you had to tell me was the worst possible imaginable place, and that was it. So I think small business owners had a very strong and reaction to this whole prospect that they would be forced to pay for these things. But it really comes down to them for a simple matters of dollars and cents. If costs go up, then jobs, wages, benefits, growth goes down. There isn't an equation where costs go up and you can pay more for employees and such, you can hire more individuals. So really there's a balance that we think would have been thrown out of whack in a situation like this. I mean, the governor and speaker's compromise, we did modeling on that in terms of the impact it would have to jobs in the state of California. The outcome was that California would lose about 41,000 jobs over the 5 years following implementation. That obviously doesn't sound like a great deal in terms of number of jobs, because we're fairly used to seeing numbers of that magnitude. However, it's important to take into account that the 41,000 doesn't look at all of the jobs lost in small business. It actually looks at the net loss. And when you look at the larger picture, a lot of the small business loss is actually offset by increases in healthcare sector employment. So that 41,000 actually is a much bigger number for small business. But the growth in healthcare sector employment certainly helps offset that. But in that case, you got to look at the situation. Does the waiter or waitress in a restaurant really have the ability to walk out of the restaurant and into surgery? That's not going to take place. So a lot of the individuals who are going to be losing their jobs are not going to be able to make that transition without a lot of additional education and skill. getting it there. Additionally, and as mentioned earlier, ERISA was definitely an issue that we believed this measure would have fallen victim to. It was a bit of, I think, on the governor and speaker's part, damn the torpedoes, and full speed ahead, because they wanted to just challenge that, throw it up there, see what sticks, kind of an attempt. It's also important to know that in opposing this reform, ultimately, NFIB was not opposing all healthcare reform. We were simply opposing this specific issue. We know, as I mentioned earlier, that something has to be done to fix the situation. That the system, as we were talking last night at dinner, it's actually pretty generous to call it a system in some cases because it's not functioning very well, or at all, really. A couple other things. Single payer was completely off the books for us. Handing that over to the government is probably the only thing worse than forcing employers to pay for it. So that leaves us in a situation where, what do? I mean, we don't like what was out there. We need to find something else. We need to figure out where we go from here. And that really set off a major effort within NFIB. A task force was put together to develop a set of principles, and we worked with our members to put this all together. And I want to run through those really quickly. And again, these are at the 40,000 foot level, and I don't want to feel like I'm cheating you in any way, so I want to make sure that's clear. The first is that healthcare be universal. And unlike the word that is so frequently, or the phrase that's so frequently used today, universal does not have to mean everybody has health insurance. Universal means, in this case, that everybody has to have access to health insurance, that it has to be available and affordable. It should be private, that we do not subsidize government programs that to the level that it begins to crowd out private coverage. That's certainly one concern I didn't mention earlier that we had with regard to the compromise was with the way things were going. We felt that either people would be, that employers would just default and let people go into the plan, in which case so many people would be in the plan that the government would be going, hey, we're doing such a great job insuring people, let's just take over the whole thing. Or that the whole system would fall apart and everybody would feel like, oh, there's nothing left but single payer. That'd be affordable. That's critically important. Again, an area where we think that the compromise bill ultimately left a lot untouched. It's unbiased. That the tax laws and the health law regulations don't unnecessarily bias us towards one product versus another. That it be competitive. That we reduce some of the burdens that that keep this current system we have locked in place. And allow for more competition among insurers, and that ultimately helps the affordability cause. It'll be portable. In the 21st century in particular, jobs, again, are moving all over the place, and people are afraid in many cases to leave jobs because they don't want to lose their health insurance. That it be transparent. And again, this is an area where I think the governor's compromise ultimately had some clauses, is that it would help educate consumers and providers, that it be efficient. We can't just be throwing good money after bad, that we need to have very effective treatments, that it be evidence-based. So we're looking at things that are working. We're looking across the country and all over for areas where things are working. It's important. That's really important because we can clearly see, and I believe a recent CBO report showed this, that there's really right now no connection between how much money you spend and the outcomes in the United States, and in the Medicare program in particular. So if you have no connection in the current system, clearly that means that evidence base is not part of the equation. And lastly, the last principle is that it be realistic. It needs to be able to work, and it needs to be able to be phased in. We can't have a situation where, day one we flip a switch and all of a sudden everybody has to make the change. That it'd be an opportunity for employers, insurers, providers, and individuals to adjust to that. As I mentioned earlier, this is the set of principles that NFIB is operating on right now. We're doing additional work to better define that with the Loon Group. We'll be doing surveys, focus groups, and other things with our members to help determine the positions and specific issues that we will be dealing with in the future. And to demonstrate, that we are, not just want to sit off to the side and snipe at people, but actually be at the table and a part of all of these discussions. Earlier, NFIB joined the Divide and We Fail coalition with SEIU, AARP, the Business Roundtable, and other groups, because if we're not a part of the conversation, then we're not there. Our members' voice isn't being heard clearly in that setting, and we want to make sure that that's the place. So, with that, I guess I will close, and we can move on to questions.
Very good. Ezra, you're getting up there. You want to take the first one?
Sure. Thanks particularly to you, Michael, who my question is at, for coming by today. NFIB obviously plays a big role in these, and I think your guys' voice isn't heard enough because, and I'm glad to have you here because I can't figure it out to some degree. I mean, you've got these 40,000 foot principles, and I hear that, but as far as I can tell, the way you guys actually end up approaching healthcare reform is we're not going to pay for it, and the government can't do it. And so I was just going on, I got a cool little air card because we don't have wireless here, and I was going onto your website and looking at what was on the healthcare side of it, and you guys have a presentation on the perfect cure, about how government reform will kill your puppies and take food out of your pantry. And then you have like the NZ bill where you can start taking down the level of healthcare everybody gets. You don't have regulations by state anymore. Is there any legislation that's come out in Congress, anything anywhere, that has any sort of bipartisan support, or in general is something that the folks on the other side of the table from you would support, and the folks in the panel before you would support, that NFIB wouldn't be completely opposed to? Because I really am trying to figure out where your principles end up, but they're so vague at the moment, as you say, the 40,000 foot, that when I heard them all, I thought, oh, that sounds like a pretty good description of the Clinton plan in '94 and possibly the California plan now, but where do you guys see them actually leading you? Because 40,000 feet is no good if all you do is drop bombs.
Well, it's a very good question. In terms of specific congressional legislation, I'll plead a little bit of ignorance. I'm focused on California so much of the time. However, that being said, I mean, I think the issue here is we're taking the steps necessary to determine what the real answer to that question is. Our members historically have had opposition to employer taxes on pretty much a variety of a lot of issues, not the least of which is this issue of healthcare. So we're taking those next steps necessary to do that. In California, I think we would have been happy to see a system that did not, absent the employer taxes, made a lot of the changes that the compromise bill included. And there were a lot of positive aspects in there that I discussed earlier. So there's a lot of things that we can support at this point in time. But in order to make some of the more difficult choices that we think may need to be made going forward, that's the impetus for the additional research that we're working on right now.
And I think it's important to understand that there was small business support of the compromise bill and of the governor's proposal. It's so that the small business opposition was not uniform.
Yes, sir.
And I'm Bob Hall with the American Academy of Pediatrics. 60% of our doctors actually are small businesses, and they struggle mightily to try to provide health insurance for the employees that they employ. I was actually struck by one of the things in the write-up on page 6. There's a really interesting spin or analysis of, at the federal poverty level, 38.5% of folks' income is for health insurance, and 17.4% at 3 times the poverty level. And the plan would have limited it to 5.5% of that out-of-pocket cost for individuals. That is a striking piece of information that I don't think has really come out in much of this analysis. I'm wondering how folks like NFIB or others who are interested in this saw that component of the plan, because that just seems to be incredibly overwhelming in terms of what individuals and small employers trying to provide coverage for their employees. How much easier it would be for that to work.
Well, in terms of the quote-unquote affordability, that certainly is one of those principles that we believe is important, that to be affordable. I mean, how you define that is a pretty difficult thing to determine. with regard to that specific provision, I mean, it allowed an out for the individual mandate, and for many businesses, for many of our members, it would not have been, or it would have, exempted some of them, but it wouldn't have exempted, very many of them. That it would have been a problem for a lot of them to make that jump. And again, they're still being required to pay for their employees, and so that's a major issue from our members' perspective. Is they're still going to be on the hook for the payroll taxes, regardless of what the situation was with that exemption.
Patricia, you want to speak to, because you developed all these different plans at different income levels. It was quite creative, so maybe you should, if you want to respond to it.
Yes, well, first of all, none of us, and I meant to, talked a lot about the subsidies that were going to be provided up to 400% of the federal poverty level, or about $82,000 for a family of 4, that would have been done in the form of advanceable tax credits or by the expansion of public programs. So there was that in order to encourage, in order to provide subsidies for people until we were able to get the delivery system, and work towards a greater affordability. We also designed these 5 tiers of benefit package, one of which, and none of the details were in the bill, but they were going to be designed in a very public process in California by the agency that runs our high-risk pool and the Healthy Families Program. And it would have started with a fairly, a relatively high benefit package. We were actually talking about $2,500 deductible, but with pharmaceuticals and chronic care for chronic conditions. I'm looking at Rick Curtis because he was at these tables, and that would have been, and preventive care that would have been outside of the deductible. That would have been first dollar coverage, and then it would have gone up to lesser cost sharing at the highest levels, and people would have been allowed to choose that with either out of their own pocket or with the subsidies that were provided to them.
If I could just add, I would just say that I think maybe don't put words in your mouth, part of what Michael was coming from when he said affordability wasn't adequately addressed, what he's really talking about is cost wasn't really addressed. And I think there are 2 different ways in which these words are used. Affordability is often the word we think about in terms of individuals paying, but cost is what it costs the system. Ultimately, the people pay for the system. So at some level, it was the absence of ability to reduce cost in the short run. I would submit it's really hard to reduce costs in the short run, and the goal is to do it in the long run. Let's move on. Rick, I see you're next, and let me just say, all of us who were involved in California owe Rick a special debt of gratitude because he did a tremendous amount of work. If anybody got more free fly miles than I did, it was surely you, and going to Sacramento. So thanks for all your work.
Thanks, Lynn. Just to clarify, it was the affordability tax credit was tied to the benefit plan you just described. Individuals, it was conceived, would be required to, if they weren't eligible for any subsidies, to have at least a $5,000 deductible. So that there ended up being a difference between those 2 things as a compromise. I'm just going to ask a question of Patricia. You did a good job of describing the structural market reforms that you and the other plans really pioneered, and everybody here should understand how groundbreaking that was and how brave that was. But it's been suggested that, gee, that kind of guaranteed access and that kind of structure is great, but there shouldn't be any individual mandate. I know that you and the other plans that worked on this feel very strongly about this, and there's good analytic reason for it, so if you would please elaborate.
Thank you, Rick. The reason is that if there's guaranteed issue, that means the right for everybody to purchase coverage without screening. But there's no either huge subsidies or requirement that people purchase that coverage. People are going to make an economic decision. And those people who don't think they need coverage won't purchase it. And those people who do will. We know this in Ohio, which has guaranteed issue, or used to have guaranteed issue without an individual mandate. And people will take coverage when they need it and they drop it. And what that results in is that people who use services buy coverage, and there's nobody there to help, none of the young and healthies are in there to help subsidize the coverage and equalize the cost. Now, the fact is, we all are going to need health benefits covered. We're all going to need healthcare services sometime. Maybe we're hit by a bus, or maybe we just get old. And it is not unfair to require everybody to be in the risk pool. That's what they do in Europe. In Europe, they mostly use health plans. and they require everybody to be in the risk pool. And that helps to equalize the costs for everybody. So that's why we insist no guaranteed issue without an individual mandate or very big subsidies like in an employer-based market where most of the cost is from the employers.
Something like 6-8 states require guaranteed issue individual market now, only 6 or 8, and I think for them it's usually one product. It's never across the board.
Well, it has the costs. If you look at the enactment of guaranteed issue in those states, the costs to the individual just skyrocketed. I think in Washington State it went up 95%, and the market basically collapsed.
Yes, 2 questions, one for Ms. Lynch, one for Mr. Shaw. For you, taking at face value what you said, not trying to put you on the spot, do you think the small business community is evolving to the point where their opposition to employee mandates, and particularly payroll taxes, is very straightforward and coherent, even if people disagree with it? But at some point, you've got to raise revenues, particularly if we're not pushing costs out of the system in the short term, as you all described. So does that mean you're evolving to the point where you're going to support some kind of revenue enhancement or tax? Because otherwise, your position really isn't intellectually consistent.
Well, as I said earlier, payroll taxes, in order to pay for health care, are not on the table for our membership. And literally, according to many economists, it's the worst possible way to pay for it because it depresses wages and has all kinds of other impacts. That being said, we're again, we're having that discussion right now. We're listening to our members to determine what other alternatives might be out there. But in terms of saying any specific ones, I wouldn't have an answer for that question, just other than to say we're looking into it right now because something does need to change in the system now.
And then for Ms. Lynch, you made a statement that the insurance companies, at least out in California, have come up with are acknowledging that they can't compete and succeed by avoiding risk. In other words, that's not sustainable. Now, I noticed you didn't mention United Healthcare because I looked at that. They did quite well last year.
United and Pacific Care. Okay, Pacific Care is United in California.
They did quite well last year, creating a risk-free pool for them. So I'm kind of skeptical. What did they tell you that made you believe that they're prepared to move out of this paradigm? It's really working very well for private health insurance.
We don't believe it's sustainable.
Now, do they?
Well, yeah.
Kaiser's a very different model from United Health.
It was not only Kaiser Permanente, it was Blue Shield, United Pacific Care, Cigna, Aetna, and HealthNet together came forward and supported these market reforms in the individual market.
Did they say anything specific that would? I'm just skeptical they want to move away from an enormously profitable business model they have right now, with no end in sight right now.
I think none of us believe that is sustainable in the long run, and that we need to have broad universal coverage, and with individual mandates, with uniform underwriting sort of standards. With the government as referee, and certainly Kaiser Permanente believes that, and my 5-sister plans, we were sitting at the table for weekends and weekends with senior leaders negotiating out the design of the individual market.
One way perhaps to think about it is the 6 plans came together and were willing to take those reforms in exchange for a package with everything else that would lead to the coverage of most Californians. So while United may not reach out and touch these reforms all by themselves unilaterally tomorrow afternoon, as part of a context in which you bring them 6 million, 47 million more insured people, then in fact it becomes more accessible. Not unlike perhaps where we can get our friends at NFIB before too long in exchange for XYZ. I guess we're all waiting with bated breath. When is the deadline? Yeah, Bob, maybe Thursday, would that be good? Is that October? Okay, yes.
Hi, Amy Morse with the Committee for Economic Development. Someone raised the excellent point earlier today that if people are interested in passing meaningful health reform in the next presidential administration, that the time to start is now. And I'm curious to hear about the foundations nationally, if there's a growing consensus of the importance of this debate and a dialogue happening at that level. Thank you.
I think there is. Last week in Los Angeles, the National Association of Grantmakers in Health had its annual meeting, and a number of us were there and really talking about moving forward with health reform. And I think the general consensus, certainly amongst the California foundations and definitely amongst some of the national large players, is this is the time to begin to work on this issue, because the conversation is going to happen in 2009. And a lot of us really believe that it's critically important that we begin to pull people together and have these conversations. You know, what happened in California is a clear case of, I mean, one of the real strategies, I will be very blunt, was kind of divide and conquer. That within each of the stakeholder groups, there are some people who can be peeled off to support reforms, but that's a process that takes time. And certainly, even within many of the organizations that health foundations fund, some of the advocacy organizations, some of the coalitions with labor, that requires that people have time to have those conversations. And so I think you will see many of the national foundations that have not already been doing so beginning to make some concerted efforts to really focus on how to prepare some of the populations that they really fund and care about to be very engaged on this issue over the next year to 2 years.
This is a very related comment, which is just that in California, the foundations were really terrific at helping get the consumer voice out there, not just through America Speaks, which was a huge undertaking and event, but through funding community groups and advocacy organizations and helping the coalition gather the stories and build the alliances that we need. So that was really, I think, a model that other states, foundations in other states and on the national level can follow. And so we urge you to be a champion for that.
Yeah. And if I can add, the foundations brought in some of the finest minds in this nation and provided grants to allow them to come and advise the legislative staff. So this wasn't some normal state legislative process where you got a bunch of people that are just wandering in ignorance. You had really top-rate health policy experts in discussing things in detail with legislative staff and the administrative staff, and it was a very, very, the foundations were extremely helpful in making that happen.
Richard?
I was going to add one thing. You're talking about the individual market a little bit, and we did appreciate the plans coming forth and working with this. But one of the things the plans really insisted on, as part wasn't just, we get guaranteed issue and they get more lives. There are also some things they were very concerned about for protections internally in the market, things related to risk adjustment and reinsurance, that kind of took care of that, or would seek either internal dollars or external dollars to take care of that very top layer of very costly people, so they'd still be able to, have a reasonable risk mix and reasonable medical, cost structure for people that were less risky. And so again, just like Mr. Nichols said, you have to look at the overall context of what was being proposed in terms of both coverage and certainly the access side for individual insurance, but that was even tempered with risk adjustment and reinsurance, so there wouldn't be big spirals going on internally in the market, and so the insurers thought they'd still be able to compete on a more level playing field, but still be able to compete and have reasonable rates and make some reasonable return in that particular market. So I just wanted to add that, because that was something that was really very important to the plans in terms of getting them to be okay. Some are very marginally okay, but still okay, so we were willing to take that.
Thank you. Thank you, Faye.
Well, I can think of no better way to end than a celebration trying to make markets work. So thank you all for coming very much.